Hello, everyone, and thank you for joining us for today's webinar. This afternoon, we'll be cutting through the hype around artificial intelligence as we explore the steps needed to build an AI-ready workforce. God, that's a good start, isn't it? Sorry. My name is Glenn Ferris. I'm the Managing Director of Healthcare Today, and I'm joined by Alex Fairweather. Alex is an AI expert and an espouser of next-gen technologies. He's also part of the team at Motix, an AI-powered healthcare automation platform that provides AI agents for clinical documentation, billing, and patient communication. Today, we're going to be covering the foundations needed to establish effective implementation of artificial intelligence, the critical skills needed for implementing an AI-ready workforce, and we'll be talking about how to adopt AI-enabled solutions without enterprise-level budgets. There will be an opportunity to ask questions at the end of the webinar, so please do put any queries as we go along in the chat box, and we will get them at the end. But in the meantime, let's get started. So, hi Alex, thank you for joining us today. I'm going to throw you right into the deep end right at the start. It's going to be a lot of questions coming your way, but I'm sure you can handle it. So, to start, a recent survey by the Royal College of Physicians found that 70% of doctors believe that the NHS lacks the digital infrastructure to introduce AI effectively, with the same percentage citing the inability to integrate AI with existing systems like EPRs as a leading barrier. To your mind, how can the NHS move forward with its AI ambitions when its foundational digital systems are described by clinicians as broken and lacking interoperability?
Well, first of all, Glenn, thank you for having me on the webinar. It's a pleasure to be here, and thank you for all the attendees wanting to listen. So I think if we break that down into 2 points, I think there's a human element, a training element, and the infrastructure element. So AI and technology training in the healthcare sector in general is somewhat of a laggard. I mean, I'm not from a clinical background myself, but having working with the founders of Motix, for example, who are, and obviously been in the healthcare industry now for 10, 12 years, it's quite apparent that the industry isn't keeping up with modern technology in terms of its medical training. So doctors are still using medical technology throughout the basis of their medical training, which is going to cause problems then, especially for the more kind of moderately aged generations in learning those technologies. So what can we do immediately to fix that? Well, we can provide CPD accredited training on new technologies that are being implemented in healthcare settings. You can offer that on a private and through medical training basis. And that's something that's very readily doable. There's a lot of material out there, a lot of companies such as ourselves willing to offer that training. On the second part, on the technology infrastructure, it's an interesting problem because the nature of healthcare is very siloed in the manner that you obviously have various medical specialties that are then combined to form the healthcare system that we've got in the UK and most of the Western world. So the question is, well, how do you provide an interoperable system where you can connect new technologies into? A cynical argument would say that, well, you can't unless you completely rip up what we know about modern healthcare and you build it again from the ground up to offer something more holistic and all-encompassing. The other solution is to provide integration, interoperability. That's two very long words. I'm struggling to get out in correct order. So integrated interoperability with new technologies connecting into existing platforms. Now, I'm aware that there has been some not legislation, that's the wrong word, but around February this year, there was guidance coming out from NHS England to say that technologies used within the NHS should be integratable, and such API keys and whatnot should be made readily available for new platforms to connect into. I think that goes a long way to solving the problem in its current form, that you can then connect legacy systems with new systems. The problem then is maintaining the integrations and then training and creating the necessary data infrastructure to run many, many different systems all connected. And from my best estimates, I think it was a statistic in 2024, there were over 45,000 different applications that were migrated to the cloud in the NHS. The total number, I don't know how many there are, but it's obviously more than 45,000, which is a huge amount. And then when you consider the pace at which new technologies are developing, new entrants are coming onto the market with new applications, it's almost creating even more work and more problem in constant integrations across different platforms, different EHRs and practice management systems with different new technologies. So what I would say is the private sector has somewhat of an advantage here because it operates on a smaller and much more nimble scale. You can kind of tear up those existing architectures and almost start afresh, migrating old data onto new systems. That would be the ideal. As things are at the moment, connecting and integrating into legacy systems with new technologies seems to be becoming more easily achievable, and can accelerate digital adoption with new technologies such as AI.
Mhm. Now, a key theme from the 10-year health plan, which we all know and increasingly love, was the public's and staff's demands to fix the basics first, such as a single shared patient record service across all services. In what ways does the current, let's call it a patchwork quilt of incompatible IT systems across different trusts, create a fundamental barrier to developing and scaling effective AI tools?
Yeah, I think a lot of what I've said in the previous answer maybe is applicable there too. I mean, a patchwork quilt, I'm assuming you mean by the different technologies, different systems
Indeed.
used to integrate into them. So, yeah, as we mentioned, there's a huge amount of work with integrating any new technologies into a huge amount of existing technologies. The single patient record is interesting. We have seen some movement on that, and we have even seen some technologies which are able to pull NHS patient records into private sector applications at NHS, which is positive. That kind of initiative is obviously going to increase the ability to provide interoperable and better connected healthcare across private hospital systems and hopefully between the NHS and the private sector, which is becoming an increasingly more frequent patient journey. I.e., starting with your NHS GP, potentially into the private sector for specialist consultations, and then maybe back to the NHS for surgery, for an example. So I think going back to the patchwork quilt, again, can we really rip up what's already there when it's so integrated and there's so many pieces of technology? Probably not. Can we consolidate those technologies? Yes, to a degree. I don't know exactly how you would do that when there's so many, and when healthcare is fragmented in the NHS, trust to trust, and geographically, and also from specialty to specialty. But from what I've seen in the industry, that is beginning to happen. You are having some consolidation there, which enables better integrations.
Mhm.
So hopefully that answers the question.
Let's move on. In an article that you kindly wrote for Healthcare Today, you highlighted that the challenge remains in providing centralized interoperability for the patient, going on to argue for private providers, a simple shared digital referral hub between clinicians can be layered with AI triage to create more seamless pathways. How can both public and private sectors learn from this approach to accelerate the move towards unified data platforms that are robust enough to handle AI workloads?
Yeah, I mean, there's some good news there that the technical bridges, at least in practice, already exist. FHIR-based APIs and HL7 interfaces, for example, are the primary data exchange platforms across NHS and private systems. They're already there, and the initiatives that we've seen with the demand for integration and interoperability with existing and new technologies used within the NHS, there is obviously some central incentivization to facilitate that. I think the question is, it comes from leadership. Now, how do we get leadership from public and private system operators talking in the same language and working towards a common goal? Now, I think that's where the real challenge is. It's not now in the technical aspects. It's in the leadership and the goals I think that the private and public sectors are working towards, which on the face of things should be the same because we should all want the best outcome for our patients. Um, in practice, where the NHS is, struggling under huge demand and not as forthcoming funding as perhaps is apparent in the private sector, you've got one side that's looking to reduce costs and reduce patient contact, the other side that really wants to increase it to a degree. So I think there needs to be a coming together from the very top, and leadership needs to identify what is best for the longevity of our businesses, and then what is best for the longevity of our patients.
Absolutely. Let's move on to the subject of people, because as we increasingly know, they need to play a part in making this all work. So, the Royal College of Physicians reports that while 79% of doctors say they need training in clinical AI tools, 66% have no access to such support. How can the NHS and private providers bridge this critical skills gap to build an AI-ready workforce?
Yeah, no, it's quite an alarming statistic. 79% of all doctors need AI training. I think I really think last year saw an inflection point with AI being adopted in healthcare. I think the fear of using new technologies such as AI has passed, and it's now almost expected for companies, certainly in the private sector, to start using it. And we have seen large scale rollouts such as co-pilots being adopted in NHS trusts. I think from the perspective of a physician, one of their key barriers is time. They have to or should be doing a certain amount of CPD work across all of across their current healthcare training and across new technologies and maybe practice management, depending on their leadership positions within their firms. That's one barrier. So I think structurally within the NHS, certainly there needs to be time allocated to technology training in general, not just AI. I also think AI and technology vendors have a responsibility. If you're going to sell, let's say, to the NHS trust based on close to 100% of clinicians using an AI technology, from a responsibility standpoint, if that's what you're pitching, if that's what you're selling, that's where your revenue's coming from, you have to facilitate that adoption. And in the case of the co-pilot rollout in the NHS, for example, I think I'm aware that only about 30% of clinicians are actually using the technology, yet essentially the NHS is paying for 100%, which completely burns your value benefit of deploying that technology. I think it costs about 1.5 billion to implement, and then the sort of projected, or the stated savings should be about 3.5 based on, close to 100% adoption. That's clearly going to be about break even or maybe slightly less if only 30% are then actually using the technology. So you need to ask the question, well, why is that? Is it because doctors or the clinicians are incapable or unwilling to use it? Is it because the technology isn't up to the standards, doesn't have the usability, the customizability functions that maybe they require, that weren't consulted on during the rollout or pilot phases? There's a lot of questions that we don't know necessarily the answers to without being involved in the deals. So I think you can look at this proactively looking forward. New technology rollouts, regardless of the size of the practice, whether it's 1-2 doctor private GP practices or hundreds of thousands of people within NHS contracts, these things need to be addressed from the start, and the provision for training to facilitate clinicians and administrative staff to use any technology needs to be considered, and it needs to be baked into that contract.
Absolutely. Well, following on from your point about Copilot, the government's own engagement found that the public is divided with significant concerns about losing the human touch in healthcare. So, how can leaders foster public trust and communicate the role of AI appropriately?
Yeah, it's an interesting statistic. So earlier research that I've done that indicates that the majority of patients are actually pretty happy with whatever technology the doctors are using, as long as they've got trust in the doctor, and the doctor has trust in that in that tech. That's obviously on an individual basis. What we've seen in the private sector is very, very small percentages of patients unwilling or fearful of using AI in practice. You're always going to have a little bit of that. You're always going to have your technophobes out there.
Mm.
But our statistics that we've seen are very encouraging in that regard. And I think a lot of that comes from openness and clarity from the physicians, which then obviously comes from openness and clarity throughout the leadership and the process of embedding that technology. So that's really the key thing. Healthcare is ultimately a people business. It's always going to be a people business. You can't roboticize a doctor-patient interaction. You can't automate a patient-doctor interaction, or at least you shouldn't try to. So I think that's where it becomes key. I think from a leadership perspective, fostering trust in the very basics, making sure the tech is effective initially, that it's not, you're not showing huge amounts of hallucinating, for example, in the case of generative AI functions, that it's accurate if you're using it in a diagnostic setting like clinical AI. Even in behind the scenes technology, such as your administrative functions, call booking, scribing, note auditing, for example. I think there has to be a level of transparency to say to your patients, we use this technology because it's more accurate, it's more efficient, whatever, it improves your patient experience. I think ultimately healthcare people focused, everything has to come down to the experience of the patient in terms of quality and efficiency of the treatment that they're getting, and that it's matching their needs. I think as long as those things are addressed and there's openness and honesty with technology that's being used and its efficacy, then that, from what I've seen, at least in practice, that goes a long way to removing these barriers from a patient perspective.
I'm going to quote yourself back at yourself here. You've previously said that AI should not replace people, but it can extend a lean team and identify personnel demand in key periods. So, having emphasized that technology should only be applied to improve the effectiveness of people, not to replace them, how can organizations embed this philosophy to ensure that frontline teams view, so we talked about patients, but how can frontline teams view AI as an ally rather than a threat?
Yeah, absolutely. I mean, I think there's two aspects to AI, clinical and administrative. If I look at it through the administrative AI lens, you're talking about practice management, administrative functions within healthcare settings. These currently are positions which are quite hard to fill and quite hard to find qualified and motivated staff. There's always a bottleneck in clinical administration. So I think the very thought of replacing clinical administrators or managers within any healthcare setting, it's never realistically going to happen. But you can, to a large degree, negate the shortness of staff and the shortness of time that they've got within these settings by using modern technologies. I mean, if you look at patient booking systems, for example, you can automate phone call, you can automate internet based booking, so patient needing to cancel, rearrange, or book new appointments, whatever, you can automate those processes quite easily. I mean, a statistic that we kind of work to at Motix is that about 70-75% of just basic mundane patient administrative tasks you can automate through various systems, which is a lot. Now, but it's not enough to replace the people that are in the business because they need to be patient facing. What it does enable then is for those people who are in direct contact with patients to be upskilled and to deliver a higher level of patient care and patient communications and facilitate a better patient experience. And I think that's true across both the public and private sectors. I'm not going to comment from a clinical AI perspective because I don't have as much experience in that setting. But again, it works very much behind the scenes, not in a manner that a patient is directly communicating with an AI system in some regards. There are maybe some exceptions to that. I mean, I know physiotherapy AI triaging systems are used on initial screenings, but it doesn't replace a face-to-face screening with that physiotherapist, for example. So I think that's probably a very good example, actually, how clinical technology can be used as well as administrative technology um, to remove a lot of the mundane burden, time-consuming burdens from staff and facilitate essentially better patient care.
Okay. Let's move on to the subject of implementation. So, a recent study published in Frontiers in Digital Health on AI innovators in the NHS found that despite significant public funding, many companies discontinued their UK operations or moved to the US after their pilot funding ended. What do you think are the main reasons for this implementation gap?
Yeah, certainly. So, I mean, I've actually got a direct quote from that study. We focused on the US, where the financing is better, the willingness to pay is higher. So we just simply shut down the operation and moved on. I think there's in the UK, especially within the NHS, the procurement cycles are incredibly long to get anything into an NHS trust. I think new technologies that have to be tested, piloted initially quite small and then at more scale and then rolled out at scale, you're talking 18 months to 2 years in some instances, where in other markets like the US, which is again a far, far bigger market, far bigger population, way more healthcare providers just due to the nature of the population difference. You also got, as the study notes, better financing, higher willingness to pay, and faster procurement times. So if you look at it through the lens of a technology provider, well, you need to do one thing. You need to ensure the longevity of your business financially. Where are you going to go? You're going to go where the money is and where you're going to get paid quicker. I think there's a lot of structural inertia, mainly due to slow decision making and fear based feelings within procurement cycles around technologies, and also the difficulties that we've got in integrating new technologies into what in a lot of cases is legacy systems. So I think there's definitely two elements there.
I'm going to
I
quote
think
you. Sorry,
go on, no, go
I,
on.
I talked over you there. Sorry. I'm going to quote you back at yourself again in another article you wrote for Healthcare Today. You've been keeping us alive. Thank you, Alex. The key to initiating changes is to start small, identify the most urgent pain point, and trial solutions to fix it. So, with that in mind, how can healthcare organizations adopt this incremental pain point focused methodology rather than pursuing large, unfunded pilots that sometimes fail to scale?
Yeah, exactly. So, I mean, if you look at an administrative function such as clinical notes, for example, we know any physician is going to be spending a lot of time on administration and note taking for their patients. Is it then reasonable if you've got 100 doctors, let's say, in a practice to say, right, you're all going to start using this technology now? How are you going to use it? For example, when are you going to use it? Are you using it in patient-facing settings? Are you using it away from patient-facing settings? It's all example questions that you need to answer, and you can only really prove those points and iron out exactly how the doctors are going to use it and how they're going to get trained if you start on a very, very small level application and then proving the efficacy and proving how exactly you're going to train people within the system and set the system up so it's going to succeed. In my experience, a lot of health technology rollouts are they're started so small, they prove a point which works, but then the adoption is then almost assumed, and a lot of factors such as training, which we mentioned earlier, are almost kind of negated, and enough internal champions haven't necessarily been recruited or brought along in the journey of then rolling out the technology. So there's definitely a couple of things there that can be better. In terms of identifying the urgent pain point, I think that very much it depends on the lens of which you're looking through it. So if it's take the NHS, well, we know doctor burnout or administrative burnout is a very real problem. We don't necessarily know the driving factors behind that. So it may be that a technology such as scribing, on the face of it, yes, it reduces a lot of doctors' time, in making the notes, we maybe don't consider then, well, what happens after the notes are taken? What happens if the technology isn't up to scratch and the doctors can't customize it, so they're then having to keep making their notes? Then how do they send letters, referrals, etc.? Can the technology be integrated, and how is it actioned in a patient-facing setting?
Let's turn our focus to the private practice. So you have identified 5 core pain points in UK private practice that AI could address. So that's administrative burden, chaotic referrals, unpredictable demand, staffing strain, and cost pressure. How can smaller clinics and private providers realistically adopt AI-enabled solutions without enterprise-level budgets?
Yeah, I mean, the simple answer now is that a lot of technology providers make the technology very accessible. A lot are based sort of run off web-based applications. So as long as you've got a computer with a web browser, which even if you're still working on Windows XP, theoretically at least, you will still be able to use the technology for as many people as you need. I think this also applies to broader scale rollouts as well, but there needs to be a view of responsibility from the technology providers. So we mentioned earlier, for example, in the Copilot rollout, it's been done on the basis of close to 100% of clinicians using the technology. And again, based on a kind of numbers of people, person-based pricing system. I think one thing that helps adoption rollout, as well as identifying obviously which pain point it addresses, is pricing your tech and putting your contracts together in such a way that incentivizes effective use of the technology rather than the people using it. So, I mean, Motix, for example, we price a lot of our contracts based on actual usage across a practice, not based on the number of staff they have. It's how they're using it. So then, even if 30-40% of the staff are using the technology and getting the value from it, well, then the practice is still getting positive value because they're getting close to 100% efficacy, stated efficacy from that technology. And if some don't want to use the technology, well, they're not paying for it. So ultimately, you're getting a fairer outcome, a fairer price. The technology company is then better incentivized to provide a quality product and increase adoption, and the practice isn't getting done over in terms of paying for something that they're not receiving. So that's certainly one thing.
Mm-hmm. To quote you again here, you have talked about AI-assisted marketing tools and how they can help small practices compete online without a full marketing team. To your mind, what are the regulatory and ethical considerations for private providers using AI for patient acquisition and marketing, and how can they balance commercial objectives with patient welfare?
Yeah, sure. So, I mean, from the research that I've done, advertising standards don't require mandatory disclosure that any content is AI generated or AI is used in marketing activities. But any claims that are put out obviously must be substantiated, which is the same if you're doing manual sort of human-based content creation. So there shouldn't be too much barriers there. Another example with the compliance and regulatory, in the CQC, their assessment framework, it requires providers to demonstrate continuous compliance with fundamental quality and safety standards, which includes patient-facing communications. And it's the same point. So it doesn't necessarily discriminate how the content is generated. It's just that it should be accurate, not misleading, and consistent with the clinical standards and services being provided. The GMC also mentioned that good practice requires doctors to be honest and not mislead patients in advertising. So again, it's non-discriminatory how the content is generated and what's used. I mean, AI is generative AI especially is particularly good at generating large volumes of content, which can then be perfected with human oversight and obviously checked for errors and mistakes. So going back to the small practice example where you've maybe got, one or two administrative personnel, with maybe a limited marketing background, well, using that technology can help that practice really quite effectively in that sense, as long as it's then being, as long as there's then the necessary clinical and regulatory oversight given to the content that it's putting out.
Highlighting the potential for public-private alignment, you've previously suggested the need for a centralized private patient navigation tool that feeds real-time demand information to providers and the NHS, which will in turn help them to align key referral opportunities. How feasible is this vision? And to your mind, what are the main barriers to creating such shared intelligence between sectors?
Yeah, sure. So I mean, it's boiling down to the issue: what's best for the patient, what's the best possible outcome. I think as the private sector has opened up over the last few years, you've got an increasing number of services available at really quite accessible price points. I mean, if you look at blood testing and health screening, for example, you no longer have to go to a GP to request blood panels. You can go to any number of different providers on the high street or online and request blood tests for well under £100, even some quite advanced ones for that price point. But then what's the pathway to connect a journey then into the private sector, then back to your NHS GP? It's maybe not the done thing. I mean, the regulatory standards are there that in the example of blood testing, the results should be uniform and at least accredited and standardized so that you know that those results are accurate, and any GP can then look at them and then go on to treat that patient with their additional assessment. I think as more consumers are using the private sector in that way for some limited treatments or diagnostics, the problem then is that they've got, well, their results, healthcare data on another platform with a private provider, or a lot of the time in PDF documents sent via email or on an app. They're then not going back to the GP in a secure way, or in a way that is then able to integrate into their complete patient record. Now, the technology has existed for years to facilitate a central patient record and interoperability between the private and public sectors. I think going back to a point in the previous question, well, it starts from the top. I think leadership in the public sector and private sector needs to be aligned to facilitate a better patient journey. And what does that patient journey look like? Well, 50 years ago, it was predominantly NHS.
Mm-hmm.
Go to your GP, have a checkup, treatments, whatever you needed was largely done through the NHS, or it was done entirely private. I think there's much more of a hybrid approach now. So as consumer demands are changing, as pressures on the NHS are changing, potentially getting worse, getting better in some instances, there's also a lot of stress on the private sector as well. You need to balance the needs of each system and each operator with the needs of the patient and the patient journeys. And that is a challenge, because consumer demands are changing, healthcare demands are changing. There's, for example, more focus on longevity and preventive healthcare, which healthcare systems aren't really very well set up to do. We're a sickness system, not a health system. Mm. Everything's built to treat sickness, not keep people well. So again, yes, you can pretty easily facilitate a central patient records, even secure sharing of patient records. But the question is then, well, how do people want to facilitate that? How does the NHS want to facilitate it? How does the private sector want to facilitate it?
That leads us very nicely onto our final section before we open to questions. Talking about the subject of compliance. Now, both public and private sectors face a complex regulatory landscape. How can health tech companies and provider organizations navigate this complexity to ensure compliance without stifling innovation?
Yeah, this is a very good question. I mean, the pace at which technologies are advancing is, and always has done and always will, it's going to outstrip the pace that regulators can move at. I think with AI, for example, the technology is becoming more mature, and I think regulators seem to have caught up with that. The MRHA, for example, there's 5 principles that they have there. Those are transparency, explainability, safety and security, fairness, accountability, governance, and contestability. There is a pretty good regulatory framework there to develop new technologies that's perhaps not specific enough in some, if you're looking at very, very key and niche applications, but it's broad enough to cover a lot of the development for new technologies that companies are trying to do. So I think regulation is advancing with technologies. The frameworks that are in place in the UK, at least, are actually quite facilitative of developing and implementing new technology. It's perhaps better than other countries and parts of the world in that regard, which is probably why the UK has actually got a very buoyant tech sector, especially in health tech, in the startup scene. I think looking at other sort of regulatory frameworks, there's a National Commission on AI regulation in healthcare, which is pretty new. December actually it was established. They're developing sector-specific recommendations, which is expected this year, which engages with the process on how a compliance obligation and innovation opportunities coexist. So there's more work being done behind the scenes. I think with the way things are at the moment in the UK, it's a pretty good setup in terms of facilitating creation and adoption, whilst also enabling sort of security for patients and healthcare systems. But I think definitely more needs to be done on the compliance side.
You've addressed this question slightly already by talking about how Motix has adopted this pay for what you use approach. But for NHS trusts struggling with finances, justifying the upfront cost of AI can be a major hurdle. How can innovators better demonstrate long-term value to risk-averse finance teams?
Yeah, I think this goes back to the pilot point. I mean, it's very easy to claim statistics and efficacies on paper based on whatever studies a company have done. But the proof of the pudding is in the eating, as they say. You roll out a small trial initially, gain the data, roll that out to a slightly bigger, so let's just say a third of clinicians across an NHS trust, for a limited time period, collect the data, and then use that internal project, as it were, to then prove the business case before you're then going into large scale, expensive deployment. I think as long as the technology companies are incentivized to do it, so i.e. they're not going to be losing money on those trial and pilot periods, and there's not a burdensome cost associated with running them from the NHS pilot, providing the due diligence is done initially to make sure that this tech is, on paper going to solve a problem and create advantages in terms of efficiencies or productivity, which are the two, I suppose they're the two main aspects. As long as that's proven, so initially the research is done, and due diligence is done, so it's proven on paper, then on a small scale and a slightly bigger scale, before you're then talking about kind of multi-year contracts and wide-scale deployments, which are then costing potentially in the billions if you're looking at deployment across NHS trusts.
Fantastic. Thanks, Alex. Let's open it up to everyone kind of watching now. If you do have any questions, please put them in chat and we'll aim to get to them. In the meantime, we have a few that have popped up, so I'm going to fire away. You're unprepped for this, Alex, so bear with. So we have a question here from Petre Ishim. I apologize if I've pronounced that incorrectly, but saying it could be a good idea to have part of the mandatory training, a training course on AI in medicine, maybe for separate specialities such as GP, general surgery, medicine, and A&E.
Mm-hmm. Yeah, I would agree with that. I'm not sure what the question is there, but maybe it's
would it be a good idea to have that?
would it be? Yes, I think it needs to be a little bit more specific. That you're then looking at, well, what functions are the technologies solving in those points. So, for AGP, for example, your main use case is going to be clinical documentation and administration that the GP is going to be using. So the training, yeah, I think there should be mandatory training within GPs and regular CPD as well, based on the technology they're using. So I use scribing, maybe phone agents and clinical note auditing. Then looking across other applications, if you're looking then purely administrative and administration tasks, well, those personnel aren't going through medical training, but they still need to be offered something to enable practices or trust, GP practice, for example, within the NHS, the benefits of those functionalities. So yeah, I absolutely agree that it needs to be provided. But again, the devil is in the detail. What functions are going to be needed within those specialities, and what functions are going to be required in those different positions. So there needs to be a pretty large scale thought piece and rollout of whatever training is being put together that's tailored and specific, not just to the problems, but also to the type of applications then being used.
We have a question here from Anil Taylor. I am a clinician working in a large NHS trust hospital. An important barrier for the use of AI is the perceived leakage of patient confidential information to the cloud. A workaround is to use local LLMs served within the firewall network of the hospital. However, it seems that the DPIA, thank you for putting the acronym here, the Data Protection Impact Assessments for the design of these local systems are not worked out very well, and there is a reluctance to expose patient identifier information within this local environment. What do you see as a solution to this?
Um, that's probably a little bit too technical for my knowledge. In all honesty, I mean, if you want to email me, I can get some very good answers from our engineers within the company. They'd be able to answer that in a lot more detail. What I would say is that the data and security regulations are quite robust. I mean, yes, there have been some pretty scary data leakage issues within the NHS. I think there was Synovius lab data a year or two ago, for example. That was from a cloud-based solution. But generally speaking, it's the security levels of security on those systems are quite robust. From what I know, I would be quite wary of doing everything anything on a local level, because the quality and the level of security that you're going to do individually is again, the sum of the parts are greater than the individual. Dare I say, the levels of security you could achieve on a local level aren't going to be as much as on sort of a bigger systems provider, such as whatever cloud-based solution you're working with. But as I said, do feel free to drop me an email, and I'll get a more detailed answer from more technically qualified people, I should say.
We will be sending a follow-up email to this with a link to this webinar. So, Anil, if you have any questions, I'm very happy to put you in touch with Alex directly. So there's a question here from Barry Clements. To avoid erroneous AI information, what do you think is the most accurate platform as regards accurate evidence? And what do you think of the Open Evidence app?
I'm not familiar with open evidence, so I can't answer that. As for what I think is the most accurate platform, I've obviously got some biases there, so I'm not going to answer that correctly. What I would say is, if any such concerns that you've got, that you can pretty easily trial or pilot whatever system you're looking at these days for a short period of time, and you can test them. There is also now I read an article on this actually this morning, and the name, I can't remember what it's called. I'm trying to remember. I'm really sorry, I can't remember. But there is a technology out there that assesses hallucinations in generative AI based subscribing. For example, there is something that exists that allows you to compare data between them. If not, it definitely exists to enable you to test it within your own setup with that tech. So yeah, I'm not going to answer what I think is the most accurate, because large degree of bias there. But yeah, I'd say it's quite readily achievable to be able to research that accurately.
Fantastic. Unless we have any other questions that come up, and we please do get in touch after the webinar. We're happy to follow up with anything you think of afterwards. I would just like to say thank you for joining us today, everybody. Thank you very much to Alex Fairweather for sharing his invaluable knowledge and expertise. And have a great rest of your day and week. And as I said before, get in touch if you have any questions. Our contact details are here. And as I said, I will very happily put you in touch with Alex directly. And if you check out this, the Motics, it's Motics. Obviously, give it a Google and you'll find all the information there to talk further to the team. Thanks a lot. Take care, everyone.